is your child tired in the morning? If the answer to that is yes, go and see the ENT straight away, because that child's in trouble. That's all you need to ask. The rest of it's just window dressing. It really is. Because if there's any sign of airway obstruction, and that can manifest with mouth breathing or snoring, and in the worst case scenario, stopping breathing, that is sleep disordered breathing. The problem is that CPAP's a really good management tool. It doesn't fix it, but it's reliant on using it, and it's reliant on everything being optimized for it to work properly. So if a person has a blocked nose or big tonsils, for example, then you're swimming against the tide until those things are out of the way.
Do you think this could be either dangerous or a mistake of dentists sending it to myofunctional therapy to convert a mouth breather to a nasal breather without first getting an opinion from an ENT?
Yeah, the short answer is yes, because we know that 80 to 90% of mouth breathing is due to some form of anatomical obstruction. It's not a habit, it's survival.
The roof of the mouth is the floor of the nose. Therefore, ENT and dentistry should be well connected. There should be an open dialogue between ENT and dentistry. But is that the case? Hell no. This is why it's a huge honor that I'm hosting today Dr. David McIntosh. He is a world-renowned ear, nose and throat surgeon for adults and children, and the highly acclaimed author of books such as Snored to Death. And you know what? Just like all of our other Aussie guests that we tend to have on, he is just remarkable and so straight talking. I love straight talking guests, and he will tell you how it is. He does not mince his words. His messaging is super clear, and he's a real advocate for airway health, and he works very closely with dentists. From this podcast, you'll learn why sleep studies don't always give you a full picture of your patient's condition. You'll also find out why David thinks you should not see a myofunctional therapist before you've seen an ENT. It's actually controversial, but anatomically it makes sense. He talks a lot about understanding the underlying cause of the sleep apnea and this concept of phenotyping patients, which I absolutely love. I do this in occlusion. When I'm assessing occlusions, I kind of phenotype them. And so it's really lovely to hear his perspective on phenotyping our patients when it comes to sleep disordered breathing. You'll get to know the 4 key questions you should ask to accurately screen for sleep disorders in children, and why women experience sleep disordered breathing differently to men. There are different symptoms and different challenges. Hello, Protrusive. I'm Jazz Galati, and welcome back to your favorite dental podcast. And this episode with David McIntosh, I tell you, it's going to go in the Protrusive Hall of Fame. This has been a long time coming, and I love the title, Putting the ENT into Dentistry. Now, if you're new to the podcast, you picked a bloody good one to join us on, and every main episode we have a protrusive dental pearl. Today's pearl comes from the main part of the episode, and it's all about how we love data, right? As dentists, we absolutely love data. We like numbers, we like stats. But actually, I'm going to give you a cautionary warning that when it comes to data in sleep disordered breathing, for example, the AHI, the Apnea Hypopnea Index, and we look at these numbers and, over 30 is severe and over 5 is mild and there's moderate, and all these numbers that we look at, they're all made up. They're all arbitrary, which is why you should take these numbers with a pinch of salt. These numbers don't account for individual patient variability, especially in women and children where you could have mild scores but really significant symptoms, which is why we need to combine this numerical scoring with the individual's anatomy and phenotype, the clinical signs and the anatomical assessment, and we're going to have a deep dive into this today. I won't take up any more of your time. Enjoy this episode, and I'll catch you in the outro. Okay. Dr. David McIntosh, ENT, welcome to the Protrusive Dental Podcast. Absolute honor to have you here to discuss a super important topic. I am itching to learn more about your world, and more importantly, how our worlds can work better together. I'm sure you've got lots of strong opinions there. For those of us who haven't come across your work before, give us a little bio about yourself.
Yeah, sure. So first of all, thank you for having me. It's a real privilege and an honor to be here. So as you highlighted, so I'm an ear, nose and throat doctor. The accent might give away that I'm not necessarily from your neck of the woods. I'm from Australia, and my journey is sort of a blend of all sorts of just fortuitous moments in time where I was just in the right place at the right time for the right reasons. And that has led to me evolving as an ENT that has a very particular niche interest in sleep disordered breathing and understanding the overlap with my specialty and dentistry, and getting a broad understanding of a lot of the things that is going on in the dental world from a pathology point of view, patient management point of view, where the outcomes would be substantially better, and they are substantially better, but when we all work together. And in that context, it's really just about, as I say, teamwork makes the dream work. We're going to get the breathing sorted, we're going to get the sleep sorted, but we need to manage all of the contributing factors. And me ignoring dentistry would be like dentistry ignoring ENT. It doesn't make sense. There's so much co-pathology going on in a lot of these patients that we can collectively make a big difference to. So that's me in a nutshell.
Thank you so much. Well, the roof of the mouth is the floor of the nose, right? And I think like it took me far too long in my career to actually just kind of realize that. Obviously, in anatomy, you know a skull, you know that, but the actual relevance of it gets like, in our dentistry, we get so into the composite resins and this, and we sometimes too late in our journey. And it's not the fault of dental schools per se, because they've got to make us safe beginners, but there's so much we owe it to our patients to learn about. And I'm sure you've seen dentists come to you and thank you for, opening your eyes to various aspects. So one interesting thing you said is that you're ENT, but you've niched more into sleep breathing. Is there like a fine line between what you do and a full-on sleep physician? Because that takes me nicely to my first question, which is, okay, the stakeholders in sleep-stored breathing, right?
Yeah.
From my perspective as a dentist, right, as a lowly dentist, my perspective says that the sleep doctor, the sleep physician is like the king. What they say goes, right? And then you've got the ENT perspective, and they are involved in that, but sometimes they don't get involved. Sometimes it goes straight to the sleep physician and it stays there. And ENT, rightly or wrongly, never get to give an input. And sometimes even the dentist doesn't get to play. So where do you think the state of care is at the moment? And what do you wish it would be if you wish it would be different?
Sure. So there's a lot of nuances to the answer there. So I think the first thing to highlight is that the systems of management are totally different when we go from one country to the next. So when giving these answers, there's always a bias to what I know that doesn't necessarily match up perfectly with what you know. And that's just because different countries do, the same thing different ways. And it's not to say anyone's right or wrong, but that's just a thing to highlight as we move through this. The other nuance is we need to be very pedantic that we do not talk about this subject as if children and adults are the same, because they're absolutely not. There is such a marked difference between sleep disordered breathing in terms of the context of children versus adults. And when it comes to adults, again, there's a marked difference in general between women versus men. So one of the problems with this conversation piece is everybody just throws it in the same bucket. And it'd be like saying you've got arthritis. Now, from a medical point of view, we understand what that means. It means that one or more of your joints are sore. But is it from wear and tear, osteoarthritis? Is it from an autoimmune disease, rheumatoid arthritis? Is it because it's infected, septic arthritis, and so forth? So arthritis as a word is kind of like a generic signpost that actually doesn't mean anything else other than the sore joint. And it's the same with sleep disordered breathing. As a term, it does not mean the same thing in a child versus an adult. And that's why, when I talk about this, I'll say pediatric sleep disordered breathing to emphasize that's the context we're talking about. So I know this is going to be a long-winded answer, and I should have warned you that I'm very good at long-winded answers. But I think it's, we're going to lay some foundations here that are going to make the rest of this easy. Then let's get those out of the way. So next foundation then is, what is sleep disordered breathing? Now, don't worry, I haven't forgotten your question, but again, I want to lay some foundation.
Yeah, sure.
Sleep disordered breathing is not the same as obstructive sleep apnea, okay? Sleep disordered breathing covers the whole gamut of upper airway obstruction, of which obstructive sleep apnea is the worst part.
Mm-hmm.
Now, the reason I'm bringing this up is because you mentioned sleep physicians. Now, the role of the sleep physician is to oversee a sleep study to determine, what is the underlying sleep disorder. And the most common one is sleep disordered breathing, and the sleep studies, and this is in children and adults alike, are, designed to diagnose obstructive sleep apnea. Okay. All right. Now that tells you if you've got obstructive sleep apnea. It doesn't tell you why.
Mm-hmm.
Okay. And this is kind of like going back to my arthritis, and I can give you a perfect example. Let's talk about adult. All right, I'm going to give you one adult version. Now, both these people, have obstructive sleep apnea. Model number one is a 47-year-old male who has a BMI of 49 versus a female who is 42 with a BMI of 20. Which one of those makes sense to you in terms of having that level of AHI? Now, in the guy that weighs enormous amount of weight, that makes sense. But for the woman, it makes no sense because she's not overweight. And the reason for that is because we're just measuring a number. We've got the same diagnosis, but we've got totally different causes. In the guy, you'd say, right, well, it's because he's overweight and, are there other factors contributing to it? But at the end of the day, being massively overweight causes the bigger picture. Whereas in women, the one I gave you, it's probably because she's got some nasal congestion, some nasal obstruction, some long-standing issues that have led to mouth breathing with skeletal deficiency. So she's got some orthognathic issues in the mix, and she's got problems with maintaining her pharyngeal tone because in women, pharyngeal tone, which is the throat staying open at night, decreases as they get older. Plus, women are more vulnerable to even just minor changes of airway obstruction for a whole host of other sort of background reasons. So it's quite possible that that woman that I mentioned to you, who when you look at it looks perfectly thin and healthy and, on paper, could symptomatically be a lot worse than that massively overweight guy. And this is the problem I want to highlight as number one in terms of just measuring things off of the sleep study. It gives you no information as to the why. It tells you nothing about that person and why they've got it. And the next problem is the sleep study is only picking up the worst part of obstructive sleep apnea. Okay. Now, I can give you, again, an example. So we talk about diabetes. So diabetes, we do a blood test. We measure your sugar in your blood. Okay. And we have lines in the sand. We actually have two lines in the sand. We have one line in the sand that says that you're diabetic, and then we have one that says that you're pre-diabetic. So the third category is your normal. Okay. Now, obstructive sleep apnea, a sleep study measures, do you have obstructive sleep apnea or not? Whereas the actual line in the sand is, do you have sleep disordered breathing or not? So this is the problem with a sleep study, because a normal sleep study does not mean normal breathing. So we can have a huge range of people having these sleep studies and being given false reassurances that they're normal, when in actual fact, that's not necessarily true. The next issue that comes with these sleep studies in terms of putting a lot of faith into them is that one night's sleep is different to the next night's sleep, which is different to the next and different to the next. And the science shows that you need to do 4 nights in a row of measuring sleep and average that out to have a much more representative sample of what's going on. So that's the next problem. If you have your sleep study on a good night, you look good. If you were to have it the next day, you look bad. And they've done this research. They've got people where they do the sleep study one night versus the next. And the difference in the same person, when they look at it then across the board, is so significant it changes the diagnosis for better or for worse 40% of the time. Okay. So which one do you believe? Do you believe the good one or the bad one? But if you didn't have both, then you can only believe whichever version you scored at the time. Okay. So that's the next thing. And the last part of all this journey is the numbers that we use, the cutoff numbers. So we talk about what's called the apnea hypopnea index, okay, the AHI. Now, that was created as a research tool back in the day as some form of just monitoring progress as you work through therapy. And in the context of that, the numbers changed as the technology changed. And then we realized that children have obstructive sleep apnea. So we started doing sleep studies in children, and we, for no good reason, used adult numbers as initial thresholds. And then we realized, oh no, children are not the same as adults, and we changed the numbers. Now, for those that are familiar with a sleep study, you would have heard of the AHI in adult being 5 or more, being diagnostic of obstructive sleep apnea, and an AHI of 1 or more for children. All right. So I'll put you on the spot here. Do you know what research was done to determine those numbers?
I don't, but I'm really fascinated by this because my eldest, who's going to be 7 soon, when he was 4, I pushed for a sleep study, and he had mild sleep apnea. He had his adenoids removed, and suddenly he was a quiet breather at night, and it was a huge. And now my youngest, who's going to be 3 next week, Well, he was actually diagnosed with moderate sleep apnea. So his AHI was higher than my oldest son's, and he's got his baby teeth, and he's got crowding in his baby teeth, and he's got all sorts, and he's such a noisy breather. Last night I was sleeping with him, he was snoring. So I don't know where it comes from, but I'm definitely interested in what you have to say.
Yeah, that's easy. There wasn't any.
Okay, wow.
The numbers are made up. There's no epidemiology that supports those numbers. Zero. So, and then, so the reason I would highlight, that, situation that we have in that context then is having one element of assessment and that determines a lifetime of care with all the flaws that come with it. And the excuse is we don't have anything better, so we just keep doing it. I just want to highlight it, so that people can sort of, fact check me and look it up. This is the reality of it all. So the big one for me is that a normal sleep study does not mean normal breathing, not even close. The next thing I want to highlight is the pathway that, is exclusive of ENT and dentistry, being the CPAP treatment. Okay. So there's not it's quite common here in Australia that adults will get a sleep study, they get diagnosed with obstructive sleep apnea, and they're given CPAP. Okay.
So is it the ENT that deals with, so is it the sleep physician in Australia
Yes.
that diagnoses it and then helps them with the CPAP, or does ENT come into that?
It's diagnosed by a sleep physician and then they prescribe CPAP. Okay. And in doing that, so CPAP is an Australian invention, and the inventor created it as a temporary measure until the underlying causes could be identified and addressed. Okay. Now, to identify the underlying causes, you need to see someone who looks inside the nose and throat. And there's only one group of doctors that do that at the end of the day, and that's us. Okay. Because I gave you that example, with the guy versus the girl. When it comes to CPAP in adults, 2/3 of patients within 12 months are no longer using it. Okay. And a lot of the reason they're not using it is because they have underlying ENT pathology that's compromising how well it can work. So, for example, they've broken their nose 20 years ago, their nose is blocked up and so forth. They've got allergies, whatever. They can't breathe through their nose, and they put on nasal CPAP. And then it doesn't work, so they've got to put the pressure up. Putting the pressure up makes it really uncomfortable. It's no good. Then they get the face mask, and the face mask feels terrible. It's got to be strapped on tight, and they get bloating from it, and they just give up on it and go, this is worse than what I had to start with. And the problem is that CPAP's a really good management tool. It doesn't fix it, but it's reliant on using it. And it's reliant on everything being optimized for it to work properly. So if a person has a blocked nose or big tonsils, for example, then you're swimming against the tide until those things are out of the way. I have this analogy that if you were to go into your kitchen at the moment and you notice that the kitchen sink was blocked, so you call the plumber to unblock the sink, that's what you're expecting. They'll come and look through the pipes. But instead, the plumber just puts a machine, which is a pump, next to your sink, and says, just push this button, it'll force the water through whenever you want it to. Well, you're going to feel pretty annoyed that they didn't actually look at the underlying reason as to why the kitchen sink was blocked.
That's a brilliant analogy. I love that.
Yeah. But we thoroughly accept the provision of CPAP to people that have had a tool that, an investigation that confirms that they've got blockages, and it doesn't tell you why, but they just get this generic treatment. Okay. And one thing I just want to highlight again, in giving you that answer, I'm up to, I've lost count now, it's more than 10 cases now where the presentation of an upper airway malignancy was with snoring and obstruction that were then treated with CPAP because nobody looked.
So is that because we're not looking enough? Because once the sleep physician makes the diagnosis, prescribes it, and if they feel like, okay, the score is better, everything's better, that's okay. And so perhaps what you're trying to say is that in healthcare, we're a bit disjointed in a way that there should be a clearer pathway that once they get the CPAP, that ENT should automatically be involved, and rather than it being a proactive thing that one has to fight for, it should be more like a standardized thing. Is that a fair way to say it?
So look, my approach is pretty simple. Any suggestion of snoring, nasal obstruction, mouth breathing, that's ENT territory as a starting point. So get one of us to physically look at it so that we can do what's called phenotyping. So what that means is we can say, So this person is of normal body weight, has a deviated septum to the left, has changes of allergic rhinitis associated with turbinate congestion, has residual adenoids, which is secondary to the fact that they've got underlying reflux, which is its own right, has resulted in lingual tonsil hypertrophy. There's also associated pharyngeal tonsil hypertrophy. They have relative macroglossia. They have a narrow maxilla and a retruded mandible. That's phenotyping. That's laying out all of the dynamics with respect to what's going on from that person from an anatomical point of view, and then serves as touch points for what needs to be sorted. So that person needs their nose fixed. They need their allergies managed. They need their reflux treated. They might need their tonsils out. And they might need a tongue volume reduction. They need some form of management of their skeletal deficiencies, one way or another, whether it's with a splint or orthognathic surgery or variations on the thing, because we know why. And it's totally different from one person to the next to the next. That's just, that's how it should be. And part of that assessment, which is where it blends into dentistry then with adults, is working out whether that person is a candidate for a mandibular advancement splint or not, because it doesn't work in everybody. They won't tolerate it if their nose is blocked. And sometimes, there's this argument of, do you use the splint or do you use CPAP? And what's lost in that conversation is some people actually need both. Some people do really, really well with both. They're in a situation where they're going to need the CPAP, but they've got lower airway compromise and collapse. But mandibular advancement mitigates against some or most or all of that, and that will then facilitate the CPAP use so the pressures can be done at a much more tolerable level, and compliance will increase and management will improve. Yeah, so, from that point of view, when we look at this whole journey of things in terms of how it should work, obstructive sleep apnea is the disease of the upper airway. That needs to be clinically assessed. And I know you can do it with scans. That's not the same. There's a whole lot of extra layers to what we can assess in real time and so forth. Not to undermine, the scans are a great tool, but they don't tell you everything. If you get a scan of the nose, for example, around about 10 to 15% of the time, because of the way the scan technology is designed, it will miss a deviated septum. Okay. So you can have a normal scan.
Well, what kind of scan is this? Sorry, what kind of imaging scan is it?
CBCT.
Okay.
Yeah, CBCT. Far better than plain films. Like plain films are really, they're looking at clouds or looking through muddy water. From a medical ENT point of view, they're like, oh yeah, let's get some proper X-rays now. Or to be honest, let's have a look at the real thing. But in the context of good quality CBCT, it will miss and underrepresent deviated septums. So again, you can get misled with the measurement tool that you put full faith in without realizing that at the end of the day, there are some, things that, at the end of the day, you're still stuck with someone like me doing that bit. And it also then sort of helps map out the plan, because a lot of patients feel lost in this whole journey of things. They've had the sleep study, they've got the CPAP, they hated it, and they don't know that there's anything else they can do. And they haven't, it hasn't even crossed their mind to think, why have I got this? And I've had patients said, look, they come in and go, oh yeah, I've had the sleep study. Why, I've got sleep apnea. I go, oh, so why have you got sleep apnea? Oh, because they found it on the sleep study. Like that's their level of comprehension.
I can relate to that a lot, and I often think about this. It's the first time I've verbalized it, and I might be talking utter crap here, but hear me out. When I'm not into like dogs. We've never had a dog pet, but my friends have dogs, and so there are certain breeds of dogs that we know because of their anatomy, because of their phenotype, as you said, right? They are more than likely going to look ahead in their life as sleep apnea. Pugs, I think, are one of them, right? So
yep, big time. Pugs are one of the worst.
Exactly. And so is there a population of people from a certain country or certain genotype that we think that, this certain population, in the absence of like weight gain, like that's obviously that can, adding more weight can affect all populations, but this certain population, because of their very small mandibles, are just likely to have sleep apnea? And actually, at what point do we say actually this is normal for this population, or actually this is still pathology and we can still add years to their life? It's something I think about, but I've never verbalized.
Yeah. So I mean, we live in a blended world these days. So we can talk about countries, but probably talk about this city more so as being more of a background rather than a country of origin. And nothing dramatic really shows up as in terms of a disparity except in one context, and that's Indigenous versus everybody else. And so people that have our Australian Indigenous population, African, the original indigenous population, their jaw structures are far broader, more developed. And we sort of speculate as that's got something to do with their diet because they're eating more fibrous foods, whereas, the Western cultures that we've grown up with, we're eating processed foods, and there's might be some epigenetics that sort of then start to play into there, and the skeletal deficiencies that flow on from that lack of stimulation. Whereas, you go elsewhere and these indigenous tribes are, literally just chewing on, like roots and all sorts of things that are quite fibrous and quite tough and getting a bit of a workout. I don't know. I think it's an interesting observation for sure. But, we're definitely talking about something that's on the rise more so than it ever used to be. And I think there's a multitude of factors that are playing into that. There's the ENT part, there's the dental part, there's the allergy part in particular. They're probably the big three moving pieces that are all blending into this overall problem, from that point of view.
Well, us dentists are taught to consider like two things that I've been taught is every patient needs a stop bang and Epworth's sleep scale, which would be ideal. Do you think that's enough, or do you think we should be adding other things? Or perhaps you have a criticism for stop bang and that actually we need to be looking at other things. For example, we need to take into account the stop bang and the Epworth, but also we need to look at the anatomy and hear the clinical or the symptoms or the signs, and sometimes override the data and go by the anatomy of the patient.
All right. So again, I'm going to wave the Australian flag. So the Epworth sleep score is an Australian thing. It came out of Epworth Hospital, which is a place here in Australia. It's a measurement of, as it says, of sleepiness. Now that is basically a representation of your pathology and your intrinsic resilience to the same. Okay. People can have horrendous obstructive sleep apnea and feel absolutely fine. Okay. So it's a very blunt tool. The criticism I've got for the stop bang is, again, it's predominantly an adult tool. We have a pediatric sleep questionnaire and bears and all sorts of stuff for kids, but the stop bang is for adults. Okay. And if you want to sort of put the stop bang out in front of you for a moment and we go point by point, and we'll do male versus female, you'll start to sort of see, why this is an issue.
Thank you to ABC of Anesthesia's Instagram page, who has a lovely image of this.
Okay, so S is for snoring, okay? S and snoring loudly. That is very typical for men. That is not typical for women, okay? So if you're a guy, there is a gender bias where you're likely to get a point and a female will miss out, okay? Tired in the day applies to both genders. So observed apneas, that is more of a male pattern as opposed to a female pattern. And there's a couple of reasons for that. One is that men, because they tend to snore more, tend to keep their female partners awake, so the females notice that they stop breathing, whereas women tend to be more mouth breathing and noisy breathing rather than snoring. Plus, the men sleep through the noise, so they are not a witness to it all. So again, you are gender specific, sort of in terms of what this is leaning towards, which means again, as a woman, you are disadvantaged on this scale.
Okay, can I just stop you there and ask on that one, observed apnea? So the way I ask it is, someone observed you stop breathing at night.
Stop breathing or choking.
And I was taught that if someone scores a yes for this, then the weighting for that perhaps should be quite high, and then that actually is more than likely going to lead to a positive or a higher up AHI. Is there any views you have on that?
Yeah. So the answer is but there is no weighting. This is a 1 or 0. This is binary. You're going to get a 1 or a 0, and that's the big problem when we look at the pediatric scores. Okay, and we can sort of look at a pediatric scoring sheet as well. High blood pressure is far more typical in men than women. Okay. BMI is far more typical of a male pattern disease than a female pattern disease. Age is discriminatory against women. The reason for that is that women, they tend to start to get this in perimenopause, which is, give or take 40 onwards. So they have to potentially live through a whole decade of misery before they score a point for being old enough to have the problem. Neck circumference ties in with obesity, which again is more of a male pattern disease than a female pattern of disease. And gender, men score a point just because they're men. They get a free kick. So you have to score, I think it's, 5 or 6, depending on which country you're in, out of 8. Women can only at best get a score out of 7. They can't get a point for being male. So they're discriminated against straight up. Plus, they miss out on the point for the snoring, and they miss out on the point for the observed apneas, and they miss out on the point for high blood pressure, and they miss out on the point for BMI, and they miss out on the point for age, and they often miss out of the point for neck circumference. So this whole stop bang is, quite honestly, useful if you're a guy, but useless if you're female.
If you were to redesign it and have a female version of a stop bang, what other letters, it doesn't have to be letters, what other points could you add
So what you're looking more in females,
find
useful? Would be nasal congestion, tiredness again, brain fog in the mornings in particular, headaches for no clear cause, would be far more relevant from a female point of view than anything that's on that list. Because of those things. When people ask me about these rating scales, that's my big gripe. Is that again, men and women are not the same when it comes to upper airway obstruction. There's a whole lot of different phenotyping that comes into it, and there's a whole lot of other different elements that come into the presentations. And it's particularly common with women that they sort of get away with it until menopause comes along. When menopause comes along, that's when their nasal congestion starts to increase, and the tone of their pharynx, or the lower part of their throat, starts to decrease. So they have the perfect storm of getting a nose that's blocked and a throat that collapses. So that's why they sort of go along, and then they sort of just fall in a heap. The upside is they're much easier to manage. The majority of them, they just need their nose fixed and they need a mandibular advancement splint, and they're back on track. But again, this is why someone like me needs to look, because, this is all speculation. It's all got to be done down to the individual at the end of the day, in terms of where it's at. Then
I've got a patient. I've got a patient at the moment. I'm managing her TMD, and she's super slim, loveliest lady. Her sleep quality is always important. I've been on her case, like, hey, we need to look after your sleep. We need to get your sleep assessed. Should my next move be to provide for her the sleep test, or should I in fact be referring to ENT, because she would score very low on the stop bang, as you said?
Yeah. So the stop bang she won't do. The Epworth sleep score, they might score a bit better because women tend to be more tired and so forth, because they're more vulnerable to just minor degrees of obstruction.
Hello, YouTube Protrusive. I know you're watching on YouTube, and I hope you're enjoying this episode so far. But I wanted to highlight, in case you don't know yet, we have an amazing viewing experience on protrusive.app, our website, our network, our platform. So I just want to spend a minute to show you what this looks like. On the left side, you see the navigation, and when you join the app, you get a 1-minute video tour of the entire network. Now, in terms of where the magic happens, that's in the Protrusive community, because you might come for the content, but you'll stay for the community of the nicest and geekiest dentists in the world. We have all these polls, we have a chat group, there's always active chats and dentists helping dentists. And really what I want to do is create a really supportive environment that's not like the environment we have on Facebook, and is built on the values of niceness and geekiness. If you are nice and geeky, you belong here. Now, to make this a safe space, we have a manual process of approval. We actually verify that you are a dental professional before you get in here. So we have hundreds of applicants a day. So if it's been about 2 days and you haven't heard anything, either something's in your junk or you need to reach out. If you're still waiting to join your tribe, email marie@protrusive.co.uk. That's MARI@protrusive.co.uk, and she'll investigate what's happened. Now, all the videos you have on YouTube are also on here, but you actually have some extra ones for free that you don't have on YouTube. So you get some bonus content that's not on YouTube. And actually, for the future, I'm not taking things out of YouTube, but some things are not appropriate for the wider public, and I want to sort of safeguard that information, which is like dentist talk, if you like. So that's why a lot of the content is only here and not on YouTube. So you're kind of missing out if you're not on here. That's why I'd love for you to join there. And if you join one of our paid plans, then what you get is access to the CE quiz, like this one, and you can get CPD or CE certificates, and also you get our premium notes. So these are a great aid memoir or revision for an episode to really cement your learning. And whilst we have ads and YouTube places ads on YouTube, we don't have that on our network. So for the paid plan, you get to see all of the premium notes without any of the ads. And of course, you get to support Team Protrusive and help us to continue what we're doing. I'm just going to gloss over the Protrusive Vault, which has all our infographics and downloadables. These are all our masterclasses at this moment in time, and we're always planning to add more. And if you look at them, there's about 1, 2, 3, it's about 7 of them. But actually, if you look at the replay section, some of the live masterclasses that I've done and some of the training that people pay for on other websites is all on there, included as part of the masterclass subscription. And if you're a student, don't fear, we have a special section for you with all the student notes, which anyone can access. So for example, here is one on exodontia. So it's all there waiting for you on Protrusive guidance. Please head over to the website, which is protrusive.app. Make an account on your browser. This could be Safari, Chrome, however you want to do it. And once you've made your login, then you can download the iOS or Android app and then log in through there. So the reason to make the subscription primarily on the website first is that you get access to a free trial, which you don't get if you do make an account on Android, iOS. If you make it on the website, you get access to the free trial and you get our best price if you sign up through protrusive.app. So our best deals and free trials are only on protrusive.app. Of course, we always put the link below in the description. And thank you so much for enjoying our videos on YouTube. But it's now finally time to level up your experience. Back to the episode.
So women usually end up in the low end of the severity as we would measure it, on a sleep study, but they're on the high end of symptoms because they're more vulnerable. They have less resilience to the problem. So, I again have these analogies. So my comparison is, if we have, me versus, a UFC fighter. Okay. Now, if I punch the UFC fighter, he's just going to look at me and go, "Is that all you got?" He punches me back and I'm on the ground crying for the next hour. Okay. And he'll go, "I wasn't even trying." And it's kind of the same with this upper airway obstruction. If I was to hit a woman versus a UFC fighter, yeah, okay, chances are in the mainstay, she'd know about it, and so forth. And so why? Because I could probably hit pretty hard. But to a UFC fighter, it means nothing. So the same punch to a woman in that circumstance is very different to, a UFC fighter. Now, I'm not advocating violence. I'm just trying to emphasize that the same thing has a different impact. It's the same. The problem with measuring it, like an AHI of 12 to a woman versus an AHI of 12 to a man, on paper looks exactly the same. But for that woman, it's almost certainly an absolute disaster in terms of their health and well-being, but they just get labeled as mild. And that's the next problem with this whole mild, moderate, severe. They're just made up numbers as well.
Yeah, definitely. They've been the theme of quite eye-opening what you said about where the numbers come from. But my patient, again, should I be getting the sleep test first or straight to ENT first to then...
Straight to ENT.
Okay.
So there's this thing where, basically upper airway obstruction, TMD and ortho are basically the triad. And these things all overlap and interplay. Often the TMD is tied in with bruxism and clenching, okay? And the most common cause of clenching and bruxing at night is upper airway obstruction. Number one. Number two is low iron. And again, females cop that and so forth. Kids cop it too for different reasons. And then number three is nasal allergies. And the problem is you can have all of the above going on. You can have nasal allergies tied in with low iron. That makes breathing and sleep an issue. You're going into physiological stress mode, so you're clenching and grinding potentially. And then your TMD starts to play up. And having upper airway obstruction, because it mucks up sleep, changes your pain threshold, so you're more vulnerable to experiencing pain as a feature of your well-being or lack thereof. So you get the ENT to look over first. Go, look, is there something here that's just low-hanging fruit? Is there something going on that at the end of the day, we just got to look, oh, look, your nose is actually blocked and congested. Let's try some nasal sprays and then circle back and maybe surgery to really optimize this and get this better. And because often what...
Should this be any ENT or should it be an ENT who's declared themselves an interest in sleep disordered breathing?
Yeah, ideally what you said in terms of the latter, but in reality, we tend to be a bit thin on the ground. But, it's an easy question to ask rhetorically. In dental world, you'll have oromaxillofacial surgeons, okay? Now, you'll have some amongst what you use that do the cancer work and the rest don't. But you don't even think twice. You go, oh, that looks like a cancer. I'm going to send that off to Mr. Smith, and you go, oh, that person's got a tricky, 7. I'm not touching that one. I'm going to send it off to Mr. Jones. They're both oromaxillofacial surgeons, but you've done the filtering within the specialty of working out, well, this is for that guy and this is for the other girl, whatever. Okay. You got to do that with your ENT. Okay. But to do that, you've also got to then educate your parents and your patients why the person that's 3 bus rides and, 6 interchanges on the other side of town in busy London traffic is the person to see versus the guy that's just around the corner. Because at the end of the day, the person that's around the corner, they specialize in, something else entirely, like, ear disease. So it's not really their jam in terms of what they sort of, focus on. And look, you just give people choices at the end of the day. But it's the same, you need one that looks after kids. You go, all right, I need to send you to the kids ENT. I need to send you to the adult ENT. Oh, guess what? This ENT does adults and kids. Great.
Total PSQ can be segmented into 4 subscores: breathing, behavior, sleepiness, and other. A total score exceeding 0.33, so 33% of questions answered positively, suggests the presence of sleep disordered breathing and demonstrates a sensitivity of 81% and specificity of 87% within the general pediatric population.
Yep. Now, if you go back to that one that we had, read out question 6.
Okay. Have you ever seen your child stop breathing?
Okay. If the answer to that question is yes, the rest of the questions don't matter.
Oh yeah. This is my son.
Yep.
Absolutely.
Yeah. But that rating scale doesn't allow for that.
Yeah. It's again no weighting.
There's no, that is really the first question to ask. And if the answer is yes, nothing else matters. It really doesn't. And this is when we break this down. It's got 22 questions. There's really, honestly, not that many that you need to worry about. Question 1. Does your child stop breathing at night? Yes, fine. All right, go see the ENT. Let's work out what's going on. Does your child snore at night? Yes, okay, go see the ENT. Let's work out what's going on. Does your child mouth breathe through the night? Yes, okay, let's go see the ENT, work out what's going on. And question number 4, is your child tired in the morning? If the answer to that is yes, go and see the ENT straight away, because that child's in trouble. That's all you need to ask. The rest of it's just window dressing. It really is. Because if there's any sign of airway obstruction, and that can manifest with mouth breathing or snoring, and in the worst case scenario, stopping breathing, that is sleep disordered breathing. That is the spectrum right there. And then the children fall into 2 groups. So we're back to kids now. They fall into 2 groups. Those that are tired versus those that aren't. Those that are tired have burnt through their resilience. Okay? Whatever resilience they had, and everyone's got, an intrinsic amount, a little bit or a lot. When they're tired, you just ran out of time. You've got 0 time. Okay? And if they're not tired, then you got time, but don't waste it. Get them seen and get them looked at, because the kids that are tired, independent of any other question or any other sleep study measurement or anything at all, that is the big indicator of lifelong badness that this child is facing by having unaddressed upper airway obstruction. So, when you sort of look at the PSQ 22 and all the questions that are on there, and again, there's no weighting to it all. There should be like, section 1, section 2. If you pass section 1, well, then you've got to do some, pretty heavy lifting to then, score enough to then justify, being assessed. But, if you just put yourself through the filter for a child, snoring, mouth breathing, stops breathing at night, and tiredness, 4 questions. That's all you need. There's a lot of other layers we can add to this. Does your child sleepwalk, sleep talk, grind their teeth at night? Do they sweat at night? Are they restless? Are they waking up through the night? Are they showing daytime problems such as learning problems, behavioral problems, emotional regulation problems, poor energy levels? Their education's not going so great. They're hyperactive. We can add these extra layers to it, but it doesn't change what needs to be fundamental. And this is the whole thing of trying to make something complicated simple. Mouth breathing, snoring, stopping breathing, night, and tiredness. 4 questions, done.
Excellent.
The rest of it, someone like me can work out. But so as a basic level of someone like yourself, you're in the dental clinic and you go, gosh, I don't have time to ask this parent 22 questions and then sit down and work out, so you don't even need to do it. You can put it on the
there are
intake
things that
form.
we look for, like, a narrow palate and crowding, all that kind of stuff we look for. But I think even at the history-taking level, those 4 questions are so powerful. So I'll make sure we can collate them in a document as the sort of the heavy filtering that we can do and work closer with ENT. But here's an interesting curveball. I'm a functional therapist, so I've recorded a few episodes now that will be probably released by the time this comes out. Myofunctional therapy, essentially, how do we get kids to start breathing through their nose? Dentists are catching on, they're getting a bit wiser, and they are starting to refer these mouth-breathing children to myo, but perhaps because of the whole thing I said right at the beginning, that channel between, especially in the UK, because there's barriers, healthcare, government issues.
Yeah.
I mean, the waiting time for my child was over 2 years, David,
Yeah,
right?
which is too long.
For kids, he's not breathing. So I went privately to get this all sorted because thankfully I could. But I couldn't see my child suffer in this way, and something I thankfully had an interest in. Even a lot of dentists come to me now and say, hey, my child's kind of doing this kind of stuff, but I don't know what to do about it. So even dentists are a bit lost. So going back to the main point, do you think this could be either dangerous or a mistake of dentists sending it to myofunctional therapy to convert a mouth breather to a nasal breather without first getting an opinion from an ENT?
Yeah, the short answer is yes, because we know that 80 to 90% of mouth breathing is due to some form of anatomical obstruction. It's not a habit, it's survival, okay? This is an alternate pathway to breathe, and they're breathing around a problem most of the time. And it basically falls into four big things, okay, from an ENT point of view. The four big things are adenoids, turbinates, deviated septum, and the one that throws a lot of people is tonsils. And you go, how does tonsils cause mouth breathing? They're in the throat. They are in the throat, but they're at the back of the throat. And they're a three-dimensional structure, but we're used to looking at them front on. We're not used to thinking about how round they are and that they actually go forwards and backwards as well. And if you think about where they physically sit, when you breathe through the nose, it goes through the nasal passages, through what's called the nasopharynx, the postnasal space, past the soft palate, and past the tonsils. And if you have big tonsils, that blocks nasal airflow. So they mouth breathe. So they are the big four. Now, blended into this around 2/3 of the time is skeletal deficiencies. And those skeletal deficiencies means that the nasal passages are smaller, the nasopharynx is smaller, the oropharynx is smaller, which means the ENT pathology doesn't have to be as bad to then be showing up and causing blockages. So like I said, 80 to 90% of the time, mouth breathing is due to an anatomical obstruction. Now, if you were to break your leg, okay, and I say, oh, you can't walk, I'm going to send you to a physio, and they're going to do some walking exercises so you can walk again whilst your leg is still broken. Okay, this is exactly the same thing. You know, you are trying to get a child to do something around a problem. That is not setting you up for success. And there's a huge danger to it from two perspectives. One is the damage it does to the supporting structure of the outer part of the nose, and the other danger is what it does to the heart. Unless you have a good, deep understanding of anatomy and physiology, what I just said is things that will just completely go past people and they've got no idea what I'm talking about. So let me try and help out. You work in dentistry, you got suction, right? Okay. Have you ever had a moment, and you may not have, but you ever had a moment where whoever you're working for bought some really cheap suction, you plug it to the machine and the suction, basically the tubing collapses on itself?
It has not happened, thankfully, but I can
You've
imagine.
been lucky. All right. Okay. Well, basically, the reason the tubing collapses on itself is because it can't cope with the pressure of the air that's flowing through. So air that flows through a tube has a natural propensity to make things collapse inwards. Okay. And the nose is no different. Now, the way that you can get someone to breathe through the nose when there's a blockage is to make them breathe harder. Okay. That's how you overcome it. You know, if something is heavy, what do? You push harder. You lift harder. What do you do if something is blocked? You can breathe harder. You can force them to breathe through the nose, past the obstruction, because you made them breathe harder. But that also changes the air pressure that's tied in with that, and that increases the suction effect of breathing in. And if you have a sort of squiz at your nose and sort of like the outer part, okay, when you breathe in, that should not collapse, all right? And the reason it shouldn't collapse is because we've got some springy cartilage that sits on the sides there that resists that. But cartilage, like a lot of things in life, it drags and sags over time. And it's elastic, and it's like a rubber band. You get a rubber band and you stretch it. Eventually, it just doesn't have its elasticity anymore, okay? It doesn't snap back. And the nose is the same. That cartilage can lose its strength, and the nose then starts to collapse inwards on itself. And that's what we call nasal valve collapse. And when you get that, that is really hard to fix, especially in a kid, The second thing then is understanding some cardiovascular physiology. So in simple terms, the heart pumps blood from the left side to our bodies, goes around the arteries, goes through the organs, is collated in the veins, and goes back to the right side of the heart. Now, Anything that's above our heart basically can rely on gravity as the main driver to getting the blood. But everything that's below the heart needs some form of pump to get the blood back. And one of the pumps is actually breathing. Okay. So when we breathe in, what that means is that our chest wall expands, the diaphragm moves. That creates a negative pressure in our chest cavity, which draws air in, but it also draws blood in. So it's way that we improve blood return to the heart is by breathing. Now, if we breathe harder, we increase the amount of blood coming to the heart. Now, the right side of the heart is not geared to deal with high volume return. So we are increasing the amount of blood that right side of the heart has to deal with. And the right side of our heart doesn't usually work very hard, because all it has to do is pump the blood from the right side to the left side through the lungs. So it's a low pressure system. But when you increase the amount of blood that it has to pump, and that right side of the heart has to then squeeze harder, that puts a strain on the heart. So that's called a right heart strain. So you can actually induce cardiac disease, heart disease, by forcing breathing through an obstruction.
And you think that this is something that potentially could be happening out there with well intended, like we know the Myo, they intend well, but because of to overcome the nasal obstruction, they're providing techniques to be able to breathe through this narrower or blocked area, and then thus causing those two issues.
Yeah, I've seen it happen. This is not speculation. I've seen this happen.
And so you don't use myofunctional therapy yourself, like for your patients?
You know, like it's any more than an orthopedic surgeon doesn't use a physio until the fracture's fixed. You know, so that's the first thing. The second thing, though, and this is important to understand, is that when you're forcing the issue, and look, children are survival machines. Okay, this kid has worked out, subconsciously, that their nose does not work properly, and that mouth breathing is the way to solve it. Okay, it's not like the kid woke up one day and gone, "Oh, stuff it, I'm going to mouth breathe because my nose is no good." Basically, they just fall into that road because that's what they've got to do to survive.
Path of least resistance.
Yeah, exactly. So then you come along and you start trying to force it. Now, this kid's brain knows that what you're trying to do, it doesn't work. Okay, so what you're actually embedding is a neural pathway of resistance to nasal breathing in the long run, because the brain is learning even more so that this is a bad idea. So, it's all about having the right thing at the right time, because, it's the same, like, if you were doing a filling, do you drill out the hole first and then put the filling, in, or do you put the filling first and then drill it out?
Of course.
It's no different. You address the underlying problem first, and then you provide the therapy that follows on appropriately to manage the same.
So to summarize that, I guess, Myo is useful to train someone to breathe through their nose, but only once the obstruction has been tackled.
Yeah. It's a rehabilitation. It's ensuring that all the dysfunctions that have come along can be remedied, but you've got to deal with the underlying issue first.
Okay. Well, David, final two questions because of time. Final two questions, sir. Okay. One is, like, you see all the stuff that dentists put out there, but particularly your algorithms and what you speak with, the conference that you go to, you will come across more these dentists and orthodontists that call themselves airway centric. Is there something that you disagree with in this world of airway centric dentistry that you'd like to publicly say that actually, hang on, I'd like to dispute something that you guys are saying?
Yeah, no, that's fair call. So look, I think the big one really is maxillary expansion and what it does and doesn't do, and what it, so people will say, which one fixes sleep disorder breathing better, surgery or maxillary expansion? Okay. Now, there's an actual problem with the question. The problem with the question is it depends on what's wrong with the person. If the person,
what kind of surgery though? I'm just trying to.
I'll give you an example. So if the person has no ENT pathology whatsoever, zero pathology, okay, but they've got skeletal deficiencies, which one is the best treatment for that person?
Expansion.
Okay. Now, if on the other side of the fence, the other extreme, this person has big tonsils and adenoids, but perfect, absolutely perfect. No equivocating. We can't cherry pick now. Perfect skeletal form and function. Which one do they need?
Surgical intervention.
Surgery.
Got it.
All right. Now we come into where it blends together. because 2/3 of the time these kids, and we're talking kids, have both. So which is better, surgery or maxillary expansion?
I'm going to jump in and say, only from what the lectures I've been to, is that the profound effect of removal of tonsil and adenoids can have on a child's breathing. I'm going to tend towards surgery.
Yeah, I'm going to tell you both. All right, and I've gave you the two extremes, and then everything in between is a blend. Okay, so depending on where that person is on the spectrum, all right, so they've got both, but if it's a little bit of ENT and a lot of orthodontic, well, they're going to get most of the benefit from the orthodontic management. But if they've got a little bit of orthodontic and a lot of ENT, they're going to get most of the benefit from the ENT. So, and this is the problem, you know, we're trying to make, again, this thing as if it's just one disease that fits everybody, which means that there is one treatment that fits everybody, and it's just not the case.
Well,
You know,
here's a
there
good
is no
question then,
point-
to help us, because tonsils we can see, and we know, we get the patient to see their tongue out. We can see the tonsils. If they're touching, that's bad. If they're generally big, that's bad. But how can dentists make a call on adenoids?
Okay, so it depends if you're using any form of radiology in your practice. And
OPGs, OPTs?
two things is either a lateral KEF, which is pretty basic, but it's something better than nothing, or you've got a CBCT. And I don't know where the UK is with CBCT, but you know, from what I gather, it's pretty archaic in terms of the approach over there. Whereas the rest of the world is basically just, we've already moved on.
Zapping everyone, yeah.
Yeah, we've already moved on.
Yeah.
But anyway, it's just, again, different countries have different mindsets, and that's a you problem.
Yeah.
But you know, so you can appraise the adenoids off of your imaging, okay? But otherwise, you don't any more than you can't expect an ENT to assess orthodontic issues, dental issues, to the level that you can do it. So it doesn't work the same way that someone like me would expect a dentist can appraise tonsils and adenoids and nasal allergies and deviated septum and etc. like I can do it. But I've been doing this long enough to look inside a kid and go, look, you know what? This one needs surgery. This one needs surgery and expansion. This one needs just expansion. And it is a spectrum, and it's kid by kid by kid. And then, you know, in terms of then in the majority, like I said, 2/3, it's both. You know, we are having these stupid arguments of territory when 2/3 of the time it's a mutual problem. And so let's just put, you know, whatever pretend differences aside and just accept that this kid is landing with two problems. It doesn't matter which caused what, we got to fix it. Now I'll circle back to what you said. The surgery is your quick fix. So again, my analogy is a child doesn't know how to swim, falls in off a boat into the ocean and is drowning. Okay? Now that child needs two things. They need to be saved and they need to learn how to swim. All right? Which one are we going to do first?
Let's save that kid.
We've got to save them. That's what we do. All right? Now, they haven't learned how to swim. You know, might be other stuff that needs to be done. Okay? We can look at all the reasons why at the end of the day, you know, after the event. But in the here and now, that child's drowning. Let's just go and save them and have the conversations that we want to have later, which have just become academic, because we've got them out of trouble, we've bought some time, and then you can start teaching them how to swim. And so what I mean by that is get the surgery stuff out the way, get the ENT stuff off the table. It's done, and then we can move on to the myo, then we can move on to the ortho, and you know, we can move on to the allergy treatments, because we've done what we needed to buy the time that that child needed, because that child was drowning. Okay. So, you know, arguing, you know, as to why the child didn't know how to swim is pointless. And just as much as it's pointless trying to teach a child to breathe when they can't, because they're blocked, you know. So, you know, teaching a kid to swim is very important, but you don't teach it to them while they're drowning. It's not the right time.
Brilliant. Another wonderful analogy. From the beginning of this episode, I think you've made a really good logical case for the role that ENTs can have and why dentists and ENT should connect more. I see some referrals from ENT regarding tinnitus where they found no ENT issue, nothing to do, and then we try and manage the TMD in the hope that it will have an exactly. So there's a lot that we can do to work together. And what I love about this episode is that you gave us a simplified framework with weighting. You gave us some weighting for especially for children. There's 4 questions to ask, which we'll put in the premium notes for this episode, as well as a good overview of, okay, adults, men versus women, why there's a big difference. Also why the reasons why ENT needs to be involved in many of these cases and you presented a very good logical argument. David, where can we learn more from you? Where can we check you out, your work, everything you put out?
Yeah. Look. So I'm a compulsive educator, and as I tell people, there's no point me knowing this and keeping it to myself. So I'm up to book number 9 on Amazon now, which it talks about things in different contexts to it all. So we talk about adults, we talk about kids. Got one about women. I have one dedicated specifically to the relationship of autism and ADHD, to the spectrum of ENT pathology. A lot of people, when they hear that, think it's all about just breathing and sleep. It's not. There's a lot of extra dynamics at play that a lot of people don't appreciate. I have one about mental health. I have one about dental health. I have one just about sleep. So I have a spectrum of touch points for people to try and sort of cover our bases. And they're all sort of on Amazon. But in the meantime, hey, look, there's everything you get for free. You just jump on the socials, use it for good, not evil.
Yeah.
As a means of just sharing the knowledge.
Well, I would definitely follow your page.
Yeah.
That's where I found you. Follow your Facebook page. And
Yeah.
I will be adding the links to the book, especially the dental one as most
Yep.
relevant as well, which I think will be great.
Yep.
And I want to thank you for your time. I really like your direct talking style. You're just so snappy and quick. Give us the answers, but give us the wonderful analogies to go with it, which is why you are a wonderful educator. David, thank you so much.
It's been a real pleasure. Thank you so much, mate.
Well, there we have it, guys. I told you that was going to be a good one. I really enjoyed my chat with David, and I definitely want to invite him again next year because he's just so straight talking, and he gave us so many gems. In fact, he gave us so much information. We probably have some information overload, which is why you're going to love the Protrusive premium notes for this episode. And actually, we've done something cool, okay? We keep innovating, we keep changing how we do things in Protrusive, and we've completely, starting from this episode, we've completely revamped and renewed the way we present our premium notes to you. We've been doing premium notes for some years now. Every episode gets summarized beautifully, and a lot of you like to print them out and really cement your learning. Guys, annotate them, but now we've upgraded your experience. I hope you really enjoy the new style premium notes. Now, if you're one of the premium members, scroll down, download it, or check out the Protrusive Vault, download the premium notes, and let us know what you think. How do you find the new version? We made it a little bit more readable, we made it more concise, and it's just very sleek and professional looking. It's a great time, by the way, to do a free trial of Protrusive and see what all the fuss is about. Download these premium notes and check them out for yourself. Of course, it's the Protrusive guidance app I'm talking about. Head over to protrusive.app, make an account, and access your free trial. This entire conversation with David also gets uploaded to Ask Jazz. That's our AI. You can pretty much chat with the podcast. Every single episode we've ever done, all of our courses that we have on Protrusive, it all feeds the millions of words into our own closed AI system. I closed because on purpose we closed our system so you don't get interference from Google and Reddit and that kind of stuff. You get information from the Protrusiverse. It's both a strength and a weakness in my opinion, but if you love everything that we do in this podcast, you will love Ask Jazz. It really shines in clinical protocols. Ask it a clinical issue and try it out for yourself. Ask Jazz is part of the Infinity plan on Protrusive, so do head over and activate your free trial to access Ask Jazz as well. This episode is eligible for CPD, and we are a PACE approved education provider. Everything you need is at protrusive.app, and I'll see you on the app, my friends. And once again, I hope you enjoyed this episode as much as I enjoyed recording it. I'll catch you same time, same place next week. Bye for now.